OsteoSignal, Episode 19. This is OsteoSignal with Neal D. O'Neal, a podcast exploring how your body's natural design connects with osteopathic science, translating complex signals into practical insights so you can truly thrive.
Welcome to the OsteoSignal podcast. This podcast is about understanding how the body actually heals, how structure, physiology, and signaling systems work together to determine whether a person is struggling with disease, merely surviving, or truly thriving. My name is Neal O'Neal. I'm a clinical osteopathic manual therapist and a physical therapist. My work focuses on translating complex physiology, neuroendocrine signaling, biomechanics, immune regulation, and nervous system function into hands-on clinical methods that help restore adaptive capacity in patients. Much of my perspective comes from years of clinical practice, combining with training in translational research, where the goal is to bridge the gap between laboratory science and what actually helps people recover function in the clinic. Joining me today is Autumn Mayberry, a fellow osteopathic manual therapist, whose work focuses on integrating structural treatment with the body's autonomic, endocrine, and visceral systems. Autumn brings a deep clinical perspective to these discussions and helps ground many of the concepts we talk about in real patient care. Hi, Autumn.
Hi, good to be here. Thanks for having us.
And helping guide the conversation is Brent Mayberry, our podcast facilitator. Brent is an engineer by training, which makes him the perfect person to ask the kinds of questions that many listeners are probably already thinking, helping translate some of the deeper physiological concepts into language that is clear, practical, and understandable. Brent, how's it going?
Hey there, Neal. I'm doing good. Good to be with you. Thanks for having us.
Okay, together our goal with the OsteoSignal podcast is simple: to explore the signals that regulate human health and to discuss how osteopathic manual therapy can support the body's ability to adapt, regulate, and recover. Today's episode focuses on one of the most important regulatory systems in the body, the neuroendocrine axis, and why understanding this system is critical for moving patients from failure to thrive, to survival, and ultimately towards thriving. Okay, so today we were going to, today's version of the podcast includes thyroid hormones in pregnancy. And if for everyone who has been listening to this series, you'll know where we're at in the series. But for those who are just tuning in with this episode, we'd like to discuss that. So one of the things we're looking at is the neuroendocrine axis, which the neuroendocrine axis is your hypothalamus-pituitary-thyroid adrenal gonadal system. And that what we call the neuroendocrine, because there's neurological structures that release hormones that affect all parts of the body, and that there's feedback regulatory mechanisms that then feed back into that system. So it's this closed loop that tries to maintain health of this system, of the organism. Okay, so today what we've done is we're in order to understand that axis and how it fails or how it breaks down and how it succeeds, what we've done is we've introduced the placenta in pregnancy as an add-on to that neuroendocrine axis, right? So it's an easy way to illustrate where the neuroendocrine axis moves and how it functions, and just see behind the shadows there to see how it really functions, or see behind the curtain, as it were. So that's why we want to look at thyroid hormones in pregnancy, so we can see how does the placenta derail this system, or at least cause this system to shift its function, and then how does that pop back for the mom after pregnancy. So the core concept here is that pregnancy equals real-time systems integration of the endocrine system, the immune system, the autonomics, circulatory system, and the biomechanical systems, all systems we work on to keep patients healthy. Thyroid hormone equals the foundational regulator of fetal neurodevelopment, maternal metabolism, and system stability. Okay, so the fetal dependence on the thyroid hormone at 0 to 12 weeks, the fetus relies almost entirely on maternal T4, so with the mom's own T4 before the fetus's thyroid comes online. At 12 weeks...
Hey, I'm going to just jump in and just ask you about T4. Is that T stand for anything?
That T stands for triiodothyroxine. Right.
Thyroxine?
So you can just call it thyroxine. I mean, triiodothyroxine would be T3, and then T4 is more the active form.
And that's a hormone produced by the thyroid.
Correct.
Okay. Sorry, I didn't mean to interrupt. And so what could you just maybe explain just briefly what is its overall goal as a hormone in a human body?
So the overall goal of the thyroxine, right, is it's the primary hormone produced by the thyroid gland, regulates metabolism, right, heart rate, and body temperature.
So is like how the body uses energy?
Exactly. So it really helps determine the body. Now, it's how cells are able to burn energy. Okay, so
And so you were saying from 0 to 12 weeks, the fetus relies on the mother's
on the
um,
mothers,
T4 availability, like how much of it is in the mother's bloodstream and how much of it goes through the placenta into the fetus?
exactly. So
Okay,
yeah, thyroxine will actually uh, transfer across the placental barrier into the fetus and provides the fetal cells the direction for how they should use energy. Uh, Now, actually, and I kind of misspoke. T4 is a prohormone, meaning it's a storage form that floats throughout the system, and it's there waiting to then be converted into triiodothyroxine or T3. That's why it's T3, the triiodo, and that's the active form that the cells actually use. But the T4 is what's produced by the thyroid, circulates around in the blood, and then there's an activating factor that converts it. So as the levels of T3 go down, the T4 should be converted into T3 so that you're maintaining levels of both, but that the T4 is always being replenished. And then that cascades down into the T3. And that's
sure.
what,
So it's just like it's kind of like a just-in-time kind of inventory,
exactly,
right?
exactly,
It's right there when you need it, and it can just be converted. You don't have to wait for it to, populate through the bloodstream. You can.
exactly,
Okay,
exactly.
cool.
If you had to do that, yeah, that would take too long. Yeah, you would have to wait too long uh, for that to happen. The thyroid would have to find some iodine and have to put it together. It'd have to get manufactured. It'd have to get to the site. Then it'd have to get translated. So yeah, it's always on board. And as you say, the just in time delivery of T3. So you don't want T3 sitting around because T3 will activate cells and cause things to happen. So you might have areas of your body that would be overactive and areas that are underactive. By keeping it in a storage form, then that way it only turns into that active part near the cell when the cells need it. Okay.
Cool. All right.
Yeah. So a very important hormone. Obviously, every cell in your body depends on that, and when it goes wrong, that can be pretty bad. So as we were talking about, so 12 weeks, the fetal thyroid begins functioning. Now, then this translates into 18 to 20 weeks. Adequate fetal hormone production develops. And of course, it's that these times before this, any problem with mom's thyroid is going to have a great effect on the fetus. But after this, the fetus is usually able to make up for its own. Like say, mom has hypothyroidism, the fetus would be able to make up for that at this point. Okay. Now the placenta preferentially transports T4, but not T3. Right. Of course, you're not going to transport an active form of a hormone across the placental barrier. The fetal cells have to tell the T4, "Hey, I need T3." And that's where that will occur. So the T4 will come from the mother, get into the fetus, but the fetal cells will tell the T4 to turn into T3. Tell euphemism. Okay, so then the fetal tissues convert T4 to T3 locally. The clinical implication is that the maternal T4 availability is extraordinarily critical in the early signaling to the fetus for growth. So if there are problems with growth and development, this 0 to 12 weeks and to really 0 to 18 weeks, those are very critical times for the fetal growth and development. And yet the fetus is not in charge of that. So mom's system is in charge of that. So it's very important to understand. Now, and again, remember this baby is taking up hormones and nutrients and et cetera, et cetera. So the placenta is deforming the thyroid, the mom's thyroid, to produce more thyroxine so that there will be enough for the fetus. But if the mom's thyroid can't respond to that or has some other problem, for example, Hashimoto's thyroiditis, I have a patient that had Hashimoto's thyroiditis, and what we had to manage was the whole T2 ring where the thyroid is innervated from and comes from. And so we had to keep the congestion down in there so the thyroxine would be adequate and be adequately produced so that the signal was getting to the thyroid. Because again, remember, what nerve is there from the placenta to the thyroid? There is none. It's a wet nerve, as we say, which,
So are you saying that the placenta, with what it produces, serves as the signaling factor for the thyroid. It doesn't necessarily come from the hypothalamus.
The mother's needs for T4 come from her hypothalamus, but the baby's hypothalamus is immature and cannot do this. And there's the placental body, there's a maternal placental barrier that keeps some hormones from going back and forth. So the baby's hypothalamus is not capable of telling the mother that it needs thyroxine. Instead, what happens is the placenta plays that role of saying, I will make sure, I am the caregiver. I will make sure that you get what you want. I will glom onto mom's system and I will force her system to give us what we need for you. In fact, at the detriment of mom, right? For example, calcium. Calcium, the mom in the group
Yep.
speaks up. Yeah, those kids, I'm telling you.
I remember. No.
Yeah, I remember I needed T4. They just wouldn't give it up. Give it back. Give it back. No, so that it's really that placenta. And that's what I mean about the placenta hooking into the neuroendocrine axis. It literally, it's on an almost equal footing with the mother's hypothalamus of forcing her system to give the baby what it needs, or give the placenta what it needs, and it can give it to the baby. So placental health is obviously incredibly important, but also
That's
just
cool. It's like a surrogate, until the baby's hypothalamus is adequately developed. That's super cool.
Yeah, isn't it? Yeah. So it's very important that placenta be able to signal as it should be able to, and that the mom's system can respond. And so, as I said, I had this patient, and my whole job was, in the early stages of the pregnancy, make sure that her thyroid and her T2, her cervical thoracic junction, would work. And as long as that was mobile, and there are things that moms can do themselves, like laying on a roll, making sure that they can flex and extend. With all of us on phones and stuff, we all get forward neck here. And so making sure that she can bend backwards. It's just one of the things moms can do early on in pregnancy. Very important right away. In the very early weeks before the fetus is very large, there's probably plenty of extra T4. The mom can produce that extra T4. But as we get more of those 12 weeks to 18 weeks, now the fetus is getting big enough and having demands big enough that it's going to derail mom's T4. And so that's where a thyroid that's insufficient is really going to show problems, right? And where we're going to see those problems first is in the mother. I guess that's really the point. The placenta is going to take anything and everything that comes along. And if the mother's hypothalamus can't make the thyroid make enough more, we'll first see the symptoms in the mother. So you're treating the mom to treat the placenta so that the placenta never runs out, so that the fetus has all it needs. But we're talking the first 18 weeks. That's pretty quick, right? Yeah. So, and then after that, even after that time, then we'll see that the mom's thyroid has been derailed, and then the placenta gives back the thyroid control, saying, "Hey, we don't need T4 down here. The blood coming from the fetus has plenty of T4 in it, so I don't need your T4 anymore." Well, then in a way, the placenta has released the thyroid, the maternal thyroid, back to control of to the mom and to the maternal hypothalamus. But can it take back control, or have they kind of wound up the thyroid and it just now can't function at the level it needs to function, even just for mom's needs? That's another thing that we're going to see, right? So you can see this,
and it's such an abrupt shift.
Yes.
It doesn't feel very nice. But
Yeah.
but it takes a while for that placenta to take over. I mean, yes, it's immediate, but as it adds more and more, as the fetus gets bigger and bigger, it's more and more of a drain on the mom. But then that abrupt release of that is really hard. It's really, really hard. And if it's hard on mom, it's going to be hard on a baby as a newborn.
Right. I mean, and what are the challenges back and forth that this placenta is trying to, to deal with two systems and to kind of be the bridge between these two systems, as Brent said, the surrogate is stressed. And then you have issues with the placenta not being effective enough, right? People, babies born without, kind of dry, if you will, like the waters are dry and they're almost gone. It's like, yeah, that's not good. That means there's systemic problems, and that placenta is part of the system of mom and of fetus. And so, that there's real problems when you're having that, which is why doctors are so concerned about that. But we as manual therapists have to understand this whole process as well and be able to step in and say, hey, that placenta is not getting what it needs or what it wants. It's kind of dying or drying up. And that means that's bad times for the fetus. What can we do for the fetus? What can we do for the mom? What's the timing here? So here we are. Right. So yeah, so maternal T4 availability is a very critical early signal. Now, physiological changes in pregnancy. Let's just go through some of this again. human chorionic gonadotropin, mild thyroid stimulation. So we stimulate the thyroid, and then that way we decrease the thyroid stimulating hormone in the system, because we don't, the maternal hypothalamus in this case, or just everybody's hypothalamus, with the human chorionic gonadotropin in the bloodstream, that stimulates the thyroid to produce thyroxine, T4, and that allows the hypothalamus and pituitary, the maternal hypothalamus and pituitary, to decrease its TSH. So a slight drop in TSH in those first 18 weeks would be normal, right? So there's no need for the brain, the mom's hypothalamus, to stimulate the thyroid with thyroid stimulating hormone if the thyroid's already being stimulated by a second factor. Okay, fair enough.
So is HCG the only thyroid stimulating hormone, or are there others?
There are others. Adrenaline, right, is going to change thyroid stimulation. Estrogen, progesterone, and testosterone. Those are all going to affect it. Since we're
cortisol, is that a factor?
Cortisol, right? Cortisol is from the adrenal gland. Correct. Yeah.
Oh, okay.
So cortisol, right? Yeah. So that stress hormone is going to change it and suppress. It's not that it necessarily suppresses it. It's just that you use up your T4 faster. Your metabolic, right? You see all the changes with cortisol, and part of that is, and we'll talk about that in a later talk, but how cortisol really affects the whole system in an aberrant way and really shifts a lot of things. We'll talk more about that later. So yeah, there are other things. So for example, the next point here is estrogen increases thyroxine binding globulin, which increases the total thyroid hormone in the body, right? So estrogen stimulates the thyroid. So HCG stimulates the thyroid. Estrogen improves how well the thyroid does its job, increases thyroxine binding globulin. How well does the thyroxine bind and then become effective and become T4 out in the system? So the result will be that the lab interpretation becomes trimester specific. So trimester by trimester, those values of thyroid stimulating hormone, which is the most common blood test for function of the thyroid, even though it has nothing to do with the thyroid itself, oftentimes what you'll see is TSH and say T4 are measured. And then, or maybe not T4, right? Sometimes just TSH. They're only looking at, does the hypothalamus think that the thyroid's doing its job effectively, or is it trying to tell it to do something and the thyroid's not able to come up to it, or is not listening? If that makes sense.
Do they look at ratios between TSH and T4? Like,
no, that's not.
No. Okay.
Let's put it this way: generally, there's only maybe one or two tests that we do in a blood test to look at thyroid function. When you go and read the literature from the endocrinologists, the research docs, they say, well, minimum 26 tests. Well, insurance companies don't want to pay for 26 tests. And
that's a lot. Yeah,
it's a lot. That's a lot of tests. And so unless there's really an obvious problem, we don't do that, right? Medicine doesn't do that. It's like, there's no point in spending that kind of money. And then certainly the patient may bear some of that. Not everybody's insurance is fantastic. So if the patient has to pay for 26 tests, did we really need all 26 of those when a simpler fix? So we always try the easiest, simplest fix. And then fewer and fewer people will progress through the system going, this isn't working. And ideally that's when they would be going, okay, let's do 26 tests. But with moms, we're certainly going to see a trimester specific levels of thyroid stimulating hormone, T4, et cetera, et cetera. So estrogen, which we'll do again in a later podcast, we're going to go through every one of these in the neuroendocrine axis. So we can understand this better. Now, there are some additional changes that are normal. So because of the increased thyroxine binding globulin, you're going to see mild thyroid enlargement, right? There's going to be a little more puffiness here around the throat. That's normal. The thyroid, the pressure on the thyroid and it's the needs of the thyroid to produce T4 are greater. And then some of the symptoms of thyroid problems overlap with normal pregnancy. Darn it. So it makes it a little hard. Like, where in there is normal and where is there the deformation of the system due to the placental pressure on the neuroendocrine axis, specifically the thyroid in this podcast, right? So there you go. You're going to have some it's really impossible for mom's system to work perfectly because there's this other agent causing changes. And so it's not as tightly controlled. So you're going to have some symptoms out on the edges going, oh, well, you're a little bit this way, but let's not overreact. It's not until you really see big problems. And again, that's why I think manual therapy has such a great chance to help this, because if we can just make it so that the thyroid can work more properly, for example, T2, and I mentioned that that's the sympathetic innervation of the thyroid, meaning that the blood flow to the thyroid is affected at T2. Then also the clavipectoral fascia, the thoracic inlet, or as some people know it, the thoracic outlet. If the thyroid drains into this area, so the throat and the thoracic inlet have to work properly. Otherwise, those hormones don't hit the bloodstream as they're supposed to and don't have the effect they're expected to. Okay, so let's talk about like hyperthyroidism in pregnancy. It's not hyperthyroidism per se, Graves' disease, the actual disease process, its prevalence is about 1 to 4 per 1,000 pregnancies. So it's really small, but that doesn't mean it's not there. And those, and I will say those are the detected ones. The issue here is that a lot of times people make it pretty far through their pregnancy. In fact, they get to the end, and if the pressure all comes off, you won't necessarily see the Graves' disease. Mom might be diagnosed after the pregnancy with Graves' disease, and therefore wouldn't be counted in the hyperthyroidism in pregnancy group. So 1 to 4 is probably low. I don't have any numbers for you, but I would expect that. So hyperthyroidism and overreactive thyroid during pregnancy is one thing that you can see. And the symptoms are going to be tachycardia, persistent tachycardia, high heart rate, tremor, heat intolerance. Now, weight loss. Most pregnant women do not lose weight, right? So if they're losing weight or they're just not gaining weight, we can almost consider that a weight loss. So seeing this, you have to kind of just be paying attention to mom and really asking her lots of questions. Now, you might notice that tachycardia, you're like, well, high heart rate, mom's heart rate may be higher anyway because she's carrying a fetus around. So it can be, racing heart can be a little harder to detect early on. Anyway. Okay. So moving on, risks, maternal, of course, the risks of miscarriage, preeclampsia, heart failure, and thyroid storm. Thyroid storms are where all of a sudden you're releasing tons of T4 and then you're not releasing any, and then you're releasing tons of T4 and you're not releasing any. That's not a smooth control. That's a thunderstorm.
That's a cliff.
It's a cliff. Well, it's a cliff, and then it's a parapet. Then it's a cliff. Then it's a parapet.
Yes.
Yeah. Yeah. Okay. And then fetal, low birth weight, fetal tachycardia, fetal goiter, and again, enlargement of the thyroid, airway compromise. Now, remember, the thyroid gland is right over the airway here. And if the thyroid is too large, then that might cut off the airway. And that would be a real problem with, since the baby has now started trying to breathe air and it doesn't have space here, that can be a real problem.
So, hey, Neal, I just wanted to ask, how does the mother's hyperthyroidism, does that have any contribution to a baby's hyperthyroidism, or are they separate issues?
I'm going to ask Autumn to chime in on this, but let me just throw, there's the mother's, and that's going to affect the baby. The baby could certainly have their own, but most of what we're talking about here is really the mother's environment setting it for the fetus as well. And Autumn, you have experience in this.
I would just wanted to just clarify. So the mother's hyperthyroidism could affect the baby with like low birth rate or, a higher heart rate for the baby.
Yes.
But not necessarily the baby's own hyperthyroidism. That might come from some other factor, some other issue. Correct?
I think you have to kind of be aware that it could be either or, because like when I treat moms, if the mom isn't quite right, the baby's growing and developing in an environment that's not optimal. And so it's going to as their systems come together, it's going to come together in a different way than a baby who was grown in a womb that was more optimally balanced, for like pHs and hormones and that kind of thing. So I think as a practitioner, when I know that a mom has been having trouble, I try and treat her, but then I try and look for the baby and go, do they have their own thing? Or are they just going to need to be able to separate from the mom's system a little bit more, and then they're going to be okay? But you kind of have to monitor both for a little bit and kind of have one foot in one game and one in the other, just in case. That's just what I've noticed over the years.
No, entirely. And as Bear would say, you can have lice and fleas at the same time. So when the mom can have her hyperthyroidism, that'll affect the baby so that it looks like it has hyperthyroidism, or the baby can have its own hyperthyroidism. And
gotcha. The reason why I wanted to ask that question was just how you as a manual therapist would approach, trying to help regulate that system? How much of an effect does the mom's issue have on the baby? And so that's where that question comes from. And so, yeah, so I think, you just have to kind of, it sounds like you have to just kind of take the
You have to
baby
try.
kind of on its own. You just have to,
Yeah.
like Autumn said,
You have to just monitor and see.
yeah, it's an either or thing. You just have to kind of see what comes up. So I just wanted to, to ask that question just to see what osteopathic manual therapy says about that approach. So thanks for going down that rabbit hole for a second.
And I think in the baby also cranial. The mom, right, you're going to have to affect her hypothalamus. So really cranial is part of that. The thyroid's part of that. T2 is part of that. And then looking at the rest of the neuroendocrine axis, what are the adrenals doing? Like we had mentioned earlier, high cortisol rates, levels, et cetera. So yeah, exactly. So actually, that's a great question. Thank you for that. Okay, so then the key mechanism here, one of the big things that we're going to see is we're going to see TSI antibodies stimulate TSH receptors. And I kind of glossed over that. So the mechanism is that thyroid stimulating immunoglobulin antibodies. So in other words, the bodies have an immune response to the thyroid, right? And actually right here, it says, I have it written down that TSI antibodies do cross the placenta and they cause fetal thyrotoxicosis, which would cause them to have the goiter, have them have an airway. So moms can cause the babies and the baby can have their own. Okay. So
it can be either or. Okay.
It can be either or, definitely.
Yeah.
And the baby would look the same. And you still have to monitor the baby and then say, now that the baby's on their own, do they spring back to normal and do they have a failure to thrive? Do they not spring back to normal? Do they have a failure to thrive? Or are they thriving and mom's effect on the baby once the placenta is not there and their baby's not sharing blood with the mom, does the baby go on its own and do just fine? That's what we want to look at.
And I think also because I treat moms and babies both, and just things that we've been learning throughout the years, but especially more intensively the last several months, is that we need to, if you're a mom that knows that you have had issues while you're pregnant, and you have tendency for preeclampsia or type 2 diabetes, gestational diabetes, any of those kinds of things, try and find a manual osteopath, because that's what we know we're talking about, that has been trained with babies. They don't always do peds. And so if you can find someone that will watch the baby, because and we learned this especially with Dr. Arbuckle, the sooner that you intervene, because the systems are still being built, they're still being integrated and trying to get that communication there. So if we can intervene sooner and be like, hey, we might need to just put a bookmark that, hey, this baby might have trouble later because mom had this. So we can kind of watch. And then as that's integrating, we can kind of pick up on those things and make minor corrections that the baby can integrate sooner and get closer to what an optimal baseline would have been.
Yeah, great point. Those birthing injuries are huge, right? They really deform the cranium and would keep the hypothalamus from being part of the team. So, or being able to keep the team in order. Yeah, exactly. So, and there's your main cause, thyroid stimulating immunoglobulin antibodies. Okay, attacking the thyroid. So basically, an autoimmune response to the thyroid. Right? They stimulate the thyroid to produce the T4. So they stimulate the TSH receptor on the thyroid, and so the thyroid says, "Hey, the brain's telling, or the pituitary is telling me to make more thyroid, so I'm going to make more thyroid." But it's actually an antibody or an immunoglobulin attacking that antigen. In this case, you would call it an antigen, maybe. It's just a protein, but it's an inappropriate attack. Yes, so you got to watch.
So that attack signals to the thyroid to produce more.
Yeah, so it stimulates
T4?
it stimulates
Wow.
it's the receptor that if that receptor is stimulated, it tells the thyroid to produce more hormone. And so here it's actually attacking it, trying to kill it, going, oh, you're a foreign body. And that actually stimulates the thyroid to make more. So you get hyperthyroidism.
It's kind of like a vicious feedback loop, sounds
Exactly.
like.
Exactly. Yeah. Autoimmunity is rough that way. So then let's look at the other side of that, right? Hypothyroidism in pregnancy, otherwise known as Hashimoto's thyroiditis. And so the prevalence of this is 2 to 3% of pregnancies. So the other one was, 0.01 to 0.04. Or actually 0.001 to 0.004. So you're not going to see that as often, but it is going to be there. And again, like I said, harder, not always picked up. This one's a far more prevalent version of thyroid problems in pregnancy. And the mechanism here is autoimmune destruction of the thyroid cells themselves. The other one was an autoimmunity to the receptor, and that ended up stimulating the thyroid cells to produce the thyroxine. And this is one where the thyroid cells that do the production of thyroxine are destroyed themselves. So slightly different version. One ups your, causes hyper, and one causes hypo. So the symptoms here would be fatigue, cold intolerance, constipation, cognitive slowing, right? Now, so all of those are linked with pregnancy except for the cold intolerance. I don't think moms are often worried about cold. They're often worried about hot, right?
No. Yes, true.
So here's your one symptom that you might be able to tell, oh, this lady is intolerant to cold. She goes, I'm cold all the time. Yeah, when ladies are pregnant, it's like, it's not
That's
usually
a red flag for sure.
right. That's your red flag. Look for that one.
Mm-hmm.
Now, and this is very serious, right? Because the risks are maternally, miscarriage, anemia, and again, back to preeclampsia. And preeclampsia can cause miscarriage and can kill the mom. So it's these problems are very dire, but our job is to smooth out the ones on the edges. If something is too far, and to recognize this, and then to send people on their way saying, hey, I just have a patient, and her spouse was in here and was talking about, oh, my wife was getting out of the car and she caused this problem in her ankle, and the doctor says she just has a tendonitis in her ankle. And it's like, and then of course they wanted her to get, put it in a boot and do this and do that. And it's like, we have to watch her for thyroid problems, because any odd tendonitis problems that you get, that's thyroid. So one of the things that the thyroid does is it tells you how much fluid, what the fluid levels in the body should be, well, including in tendons and ligaments. And so one of the things is people will get tendonitis quite easily. So I have, we all have moms coming to us all the time for decurvain tenosynovitis. They'll have thumb tendonitis, shoulder tendonitis. Of course, they're saying it's because I'm holding the baby, but it's because of the thyroid. And so that's one of the things you might pick up on. So this lady is already having a tendon problem about halfway through her pregnancy. And it's like, okay, we really have to watch her for heart rate changes, anemia, those preeclampsia things, headaches, chronic headaches. And we really have to watch mom for that. So again, more things that you can clue into to say, oh, is it maybe a problem that a patient of yours has, or is this a problem that you might have? So now on the fetal side, this is impaired brain development. Well, none of us want to see that. And again, low birth weight. So those are both really big problems. So very important to watch and keep track of what's going on with mom. And again, if you as a therapist recognize this early on, or you as a patient recognize this early on, go speak to your healthcare provider. We have to be right on top of this stuff. Okay. So the treatment maternally for hypothyroidism is levothyroxine, T4 only. The dose often increases due to increased binding proteins, increased plasma volume because of the mom. Say the mom already has thyroiditis, Hashimoto's thyroiditis, and she's taking levothyroxine. The dose often increases during pregnancy. And if it's not, that's a question, again, you want to ask your patient. Are they, or for those patients who are listening, are you getting an increased levothyroxine during pregnancy because of the increase in binding proteins, because of the increase in plasma volume, increased placental metabolism? There's a lot more challenge on that thyroid. So you have to make sure that the amount of T4 available goes up, just like we talked about in the first 18 weeks. We really have to watch that. And of course, monitor every 4 to 6 weeks, and avoid T3 containing medications. I don't have any examples of those. I'm pretty sure they're going to have a warning label on them. So, okay. And then the third level of thyroiditis that we have to worry about, postpartum. So postpartum thyroiditis, the prevalence is about 5% of women. And again, back to those tendinitises. And like I said, you can sometimes see that during the pregnancy. And then, of course, that means after the pregnancy, it's, expect this. Tell the patient, all right, we'll be working on all that. And that's why you want to try and manage it as best you can during the pregnancy, because after the pregnancy, it's going to have a huge effect, not only on their physical health, but their mental ability to, the postpartum aspect of it. Do they get postpartum depression? This is going to feed into that. So oftentimes early postpartum, we see a hyperthyroid phase because they've been producing so much T4. In fact, they were producing enough T4 for them, the placenta and the baby, and then the placenta and the baby go away and they have all this T4. And it takes a little bit of feedback from the hypothalamus to say, whoa, too much, no more, and to slow it all down. then after some, that isn't always a long period of time, but it can be months, then we will see the hypothyroid phase. So really expect to see this rebound version of this, and to be able to help the patient with that and to help them write it out, but also know when to refer out to their physician and say, hey, this is at a level that has to be medically treated, right? Autumn, you see this all the time, right? I mean,
I do. And actually, since we've been talking about this a little bit more, especially since the February class when I did my neurobiohacker thing, we started talking about this situation with the thyroid, like just this deeper dive of seeing how the placenta interacts with the thyroid has been able to help me even with my postmenopausal patients and stuff to see, oh, that's, even though the placenta is not there, like talking about how it interacts with the placenta and then how it doesn't has helped me understand the thyroid better just in and of itself and recognize, hey, what I'm dealing with here is not actually a joint problem. It's actually a thyroid problem. And so some of them already have been able to go and get their thyroid checked and be like, because they're like, no, my thyroid's fine. And they're like, nope, it wasn't fine. so, and then, but then, treating the joint, it didn't help. And then when we come back, we're like, yeah, I mean, I'm still learning. I'm 22 years in, right? But I'm still learning. And if, usually my joint treatments are they're pretty slick, right? I mean, it's pretty easy. You got it done and whatever. And if you're like, it didn't go away. I mean, I'm good enough now where it's not because I suck. It's because I'm treating the wrong thing. And so being able to, do this deeper dive with the thyroid and the pituitary, hypothalamus, all that kind of stuff. And remember, oh, okay, especially now having been pregnant myself and remembering going, oh yeah, I probably didn't get support then like I needed to. And it makes a big difference. So throughout the hormonal, cycles that we get, men and women, and I'm picking up on more thyroid issues with men. So, which is interesting. It's not as maybe prevalent, but it does happen. And so now I'm, at least thinking of it better. So I appreciate the focus on it. And then like the deeper dive that we're doing, it's really helped me quite a bit in my patients too.
Yeah, awesome. And I think that's just it, is an awareness of it. And again, that's why we're using the placenta as a means of illuminating it. And then we start seeing it and like, oh, this isn't that situation, but now they're postmenopausal or they're postmenopausal, right? Andropause for men. Certainly you see that in changing hormones, you're going to see a shift in that neuroendocrine axis, and parts of the endocrine axis are not going to be able to change how they've been reacting for years. So they might get stuck where they're at, and those people need help. And our job is to recognize that stuff. And sometimes it's only this big, but we want the person to thrive, not just survive.
Yes. Yep. And get rid of it while it's dysfunction instead of pathology.
Right. Exactly. So now the outcomes, some people fully recover, right, after postpartum thyroiditis, but some develop permanent hypothyroidism. So yeah, just as you said, you really got to manage this. Just some things that we do want to throw in, nutritional considerations. Now, I'm not a nutritionist, so I want these are just the advice that nutritionists give. Iodine requirements, 250 micrograms per day in pregnancy. So the iodine requirements, so for those of you eating kosher salt only, you have to get iodized salt, or there is iodine supplementation you can take. So Dr. Bonner's iodine, or I forget what it is, but there is iodine supplementation you can take, and that's very useful. Prenatal, before you're before you have a baby, 150 micrograms of iodine per day. So you want to be getting iodine. We all need to be getting our iodine. And some of those sources are dairy, seafood, particularly seafood, eggs, and of course, iodized salt. Now, on the other hand, you also have to be careful not to get excessive iodine, because that leads to dysfunction as well. Now, I just want to throw this out there. Now, on the chemical chart, if you look at the row of chemicals, right, of atoms basically that iodine is in, iodine, bromine, chlorine, fluorine. Now, the problem is we fluoridate our water, and the whole problem with the water is that the fluorine is far more electronegative because it's lower on the chart. It takes up electrons far more readily than iodine does, meaning that if you're ingesting fluoride, it will replace the iodine in your thyroxine. Well, then it's not thyroxine, it's something else, right? So it's not triiodo, it's trifluorothyroxine. Well, for the T4 to the T3, I was like, well, that's not going to help you any. And then, so you come in contact with it. So some people need to be aware that it can be fluoridation that's causing you a problem, and get something on your home filter or wherever you get your water and make sure there's not fluorine in it if you have that problem. Chlorine, so swimmers, people who are in pools a lot, if you're near any other sources of people have a hot tub, you have to be careful about getting too much chlorine. And there's various things you can do about that. Vitamin C apparently is a way to really, like even just like in a shower that there's shower heads and stuff, something to look into. Bromine is now being used as a preservative in foods. So a lot of like you go out to have a dinner someplace and you get a salad, and the salad has a little bit of funny, and it's got a little oddity to it. And then afterwards you may not feel so well. That may be bromine. Bromine's a preservative, and it's supposed to be perfectly okay for humans, but anything in large amounts is not good. Even iodine itself, which we need. But so you have to also understand that the chemical properties of iodine, bromine, chlorine, fluorine, that those other three are far more likely to be in your thyroid and interact with the chemicals going on there and interrupt this process. So then you still won't have the right amount of T4 for you and your baby, or just you. So something to also be aware of, to throw that in. That's where the men come in too. Is like, are you aware of this? Okay. So then breastfeeding considerations. Levothyroxine is considered safe. Methimazole, a low dose, is considered safe. And
these are supplements that help the thyroid to produce what it needs to produce. Yeah,
exactly. Yes. So, and that's just it. Which are the ones that are safe for? Hold on, let me pull up exactly. So, so my next point was what's called PTU, which is propyl thiouracil, are they're two of the primary antithyroid drugs, right? So there's they manage hyperthyroidism, right? So we have levothyroxine for hypothyroid, and then methimazole and PTU for hyperthyroid. So they actually take T4 out of your system. So, and those are both okay for breastfeeding. So whether you have hypothyroidism or hyperthyroidism, there are medications that are considered safe for breastfeeding. Now, remember that though, if you're taking those and the baby is breastfeeding, they're going to get that. It's going to affect theirs. Now, ideally that the levels are not so much, but we have to, again, we have to watch the baby. We can't just go, oh, it ought to be okay. And then
almost like a titer.
Exactly. We still have to be careful with those things. So it's considered safe, but that doesn't mean it's going to work perfectly. So again, a knowledge and awareness and knowing you have to look closer at these things. Ask your patients which drugs they're on or which medications. And they're saying, oh, I was told by my doctor that's okay. But does that mean that you're also watching the baby and making sure that they don't have stimulation of their own thyroid from these things? Or do you limit the effect of the stimulation by treating the baby? And just like you've already done, you were already doing that. You're already treating T2, etc. Okay.
I'm going to just jump in real quick and ask Autumn to elaborate on what a titer is. I think, if you have chemistry experience, you know what that is, but just for the average person who may not, or may not remember their high school chemistry, what is that?
It's like we talked about it before. I think with the vaccine episode, where you talk about like if we could give a small amount to a patient or a recipient, and then monitor how they respond to it to see if they're a hypo responder or a hypo responder, or if they just they kind of are more at the average, so that you're catering the dosage so it's more appropriate for that person's physiology. If I understand that right, Neal, is that right?
Yeah. So it's just a measure of concentration in the bloodstream. You're going to look at that titer, like how far down, how concentrated is it? And is that a level that has a therapeutic effect? Does it have a negative therapeutic effect in that you're overdoing it for the baby or for the mom? So when you do a titer, you're really looking at, is this in therapeutic range, or is it above it or below it? If it's below, then it's not enough. If it's above, we're doing too much. And so you'd want to watch the mom and the baby, is what she was kind of saying.
Yeah.
So,
and you can make an adjustment, ideally based on what you find out. So
exactly.
All right. Thanks.
Okay. So the hypothalamus-pituitary-thyroid axis, right? We have the hypothalamus releases thyroid hormone, and the pituitary releases the thyroid releasing hormone. So the hypothalamus says, hey, pituitary, you should tell the thyroid to do something. So here's some thyroid releasing hormone to tell the thyroid to do something. It's kind of like, tell your friends who tell your friends who tell your friends. Then the pituitary releases the TSH, right? Thyroid stimulating hormone. Then the thyroid says, hey, I've been stimulating. I'm going to release T4. And that T4 goes out in the bloodstream, and out in the bloodstream where the cells are, when the cells need T3, they say, hey, there's a factor in the blood that says, hey, turn that T4 into T3. That's something I can use, because the cells themselves cannot use T4. They have to use the T3. And then just pregnancy adds complexity to this whole thing. The placental endocrine signaling throws a monkey wrench into it. Immune modulation, right? There's a lot of autoimmunity into this. So that will be one of our aspects of this current series. This smaller focus series will be autoimmune regulation within the hypothalamus-pituitary-adrenal gonadal axis. There will also be increased metabolic demands in pregnancy, right? So that changes what levels the mom might have been on T4 or levothyroxine, or everybody's demands are going to go up in this situation. So we really have to watch that. Back to the titer thing. And then the autonomic and vascular shifts. The autonomic nervous system and the vascular beds shift. Is mom and the placenta and the baby able to move fluids around from one container to another effectively to A, keep chemicals mixing, but B, to not let anything get too diluted or too concentrated, and to keep new, fresh stuff coming in and moving out, and old stuff moving out. Okay. And the autonomic expression, hyperthyroid. Hyperthyroid is kind of sympathetic amplification, if you will. Again, back to T2. Hypothyroid is metabolic dampening. And metabolic dampening, really, we're looking at immunity, which we're talking parasympathetics, and particularly in this case, vagus nerve. How is the vagus nerve functioning in relation to the thyroid? Okay. So osteopathic structural considerations, anterior cervical fascia is important, hyoid and strap muscles, the thoracic inlet, as we talked about, so for lymphatic and venous return, superior mediastinum, this upper area of the chest, the upper thoracic sympathetics, T1 through 4, really affect the head and neck. They're going to have an effect on thyroid, specifically T2, but some T1, some T3, a little bit T4. And then occiput to C2 for the vagal and cranial base, for that vagal ganglia that's anterior to C2 here. So those areas have to work right. We talked about cranial, upper cervical, and then pregnancy-specific mechanical influences, diaphragm tension for venous return, immune shifts, so postpartum flares, and circulatory changes, endocrine transport. So we have to make sure that all those areas are working together to maintain just the mom and the baby's responsiveness and ability to maintain their own health and to thrive. So the questions you want to ask yourself as a clinician is sympathetic tone elevated T1 through 4? Is vagal tone reduced, or is it responsive? Is cervical fascia restricted? Is the thoracic inlet congested? Is the cranial base affecting regulation? And with the postural changes moms go through, those are all yes right off the bat, right? So just the process of pregnancy itself causes these very problems. So really, structure, autonomics, circulation, endocrine regulation. We have to have the structure function properly. The autonomics have to be responsive. Circulation has to occur and can't get backed up. And then we can have proper endocrine regulation. So key takeaways: thyroid dysfunction is unequal to being purely hormonal. It's neuroendocrine, it's immune mediated, it's mechanically influenced, it's autonomically expressed. All those things are a big part of it. The first trimester, critical window, maternal T4 is very dependent on mom's T4 at that point. So being able to pick these up before somebody gets pregnant, they're not always your patient then. Postpartum, that high volatility phase, and being able to help the patient manage that. And then optimal care, medication if they really need that, monitoring, and a systems-based support, which is what we do, the osteopathic manual therapy. Help that system be as responsive as possible. Okay, so that and that's really the focus of this whole series. So hopefully, anything you guys wanted to add on that?
I just think it's really cool that we can affect all these different things, and yet you see it all the time, and you're like, wow, that's just like these systems are so amazing, and yet just touching them and using these signals like the bioelectrical, biochemical, and biomechanical, that it can have such a huge difference in how each one functions and how they integrate with each other. It's pretty awesome, and it really does work.
Yes, exactly, and that's just it. When you see these just small things that we do affect the patient so much, and it really makes you happy that you do this job.
Yes. Yep. It makes it worth studying and exciting to study too, that you're like, wow, we can actually do this. If we can figure this out and then get it to come through our hands, we can do it. It's great.
Exactly. Okay, so in closing, I just want to say, at the end of the day, the body is always trying to heal. It's always trying to adapt. The question is, what's getting in the way? In this episode, we really explored how the system works, particularly in pregnancy, in the neurohormonal axis. How does it really help keep health, restore, maintain health, allow the organism to not only function but to thrive. And it doesn't come from forcing change. It comes from restoring the conditions that allow change to happen. We're not forcing anything. We're not healing anything. We're removing barriers to proper functioning of the system. So when we improve biomechanical alignment, bioelectrical signaling, biochemical environment, we're not chasing symptoms anymore. We're upgrading the system. And when the system is supported, the body doesn't just survive. It starts to adapt, regulate, and thrive.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neal. For more information, please visit PursuitPT.com or PursuitPerformanceTraining.com. Want to show your support for the podcast? Give us a like, click subscribe, and leave a comment or review. We appreciate it. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neal.